Good afternoon. So, what I'm going to present you are the results that we have, of analysis that we have conducted in this core study that is called INCUR on frailty in nursing home. First of all, these are my disclosure of interest. The study, the INCUR study, is an observational study funded by Pfizer, however, for different reasons, different objectives. So there is no conflict of interest with my presentation. First of all, I would like to start with the definition of frailty, proposing the theoretical definition of frailty that I think is the most accepted definition. This is the frailty consensus published in JAMDA 3 years ago, and I think is the most agreed way to define frailty. And I think it is evident because there are the two major schools of thought in this field, Rockwood and Fried as co-authors of this definition. So I think this may be suitable for 99% of the persons. Frailty as a medical syndrome with multiple causes and contributors that is characterized by reduction of reserves and exposure to negative health-related events. And I start with this, and I will talk about the Frailty Index by Rockwood, because I think that we are talking about instruments here. This is a paper that I recently published with several colleagues throughout Europe and even outside of Europe, trying to make the point that frailty is a condition and the tools that we are using for measuring it are another thing. So I'm talking here about a Frailty Index, not because I'm a big fan of Rockwood or that kind of approach to frailty, but I think that that is a suitable tool for a specific objective and a specific setting that I'm going to show you. So just to be flexible in the approach to the topic. What is the Frailty Index by Rockwood? I think there is a lot of misunderstanding about this instrument because when they published the first paper about this tool, they provided this 70-item list, and everyone is scared about this because administering a 70-item questionnaire is unfeasible in the clinical practice, and this has led to sometimes some misconceptions about this tool. Actually, it is not so difficult to be implemented because it can be easily summarized in this simple arithmetical formula. It's the number of deficits that the person presents divided by the number of deficits that we count, independently of which are the deficits that we consider in the computation of the score. We need just to have 30 deficits included in the Frailty Index to get a reliable results. So this means that if I count 30 deficits in a person, and a person has 10 deficits present, the score is 10 divided by 30, 0.3. The range is between 0 and 1, with the higher score as the worst frailty as possible, and 0 is as the most robustness possible. The Frailty Index is very different from the frailty phenotype. The frailty phenotype has characteristics for which it is based on predefined criteria, whereas the Frailty Index is not. One is based on signs, on symptoms. The other one is based on diseases, physical disabilities, any kind of deficit that we can consider. The frailty phenotype by Fried is a categorical variable. The other one is a continuous variable. And also the relationship between frailty and disability is different between the two. The frailty phenotype is looking at a pre-disability state of vulnerability. The Frailty Index includes disabilities in the computation. So they are very different measures. And this does not mean that one is better than the other. It means that they are capturing different things for different purposes. The Frailty Index, I think, is a good measure of biological aging because it's a measure that is based on objective data, on an arithmetical assumption, and is also sensible to modifications over time. These are two graphs from two studies in which it is shown that the Frailty Index is age-dependent. So there is an increase with age of the Frailty Index because the number of deficits accumulate with age. And also there is a modification of the Frailty Index on the right-hand side, in which the Frailty Index is moving over time towards a normalization of the distribution of the score. So it's something that is really measuring the age, the biological age, rather than a physical condition as in the frailty phenotype. And the concept of the Frailty Index has also been translated in animal models. This is a Frailty Index defined by always the group of Rockwood to show that there is a potentiality for translational research because we are talking about biological age. It is called frailty, but the meaning is biological age, and we can measure also in animal models, so finding a strong correlation between humans and other species. Coming to the point of this presentation, what I'm going to show you is the implementation of the Frailty Index in INCUR. INCUR is a database that has been built in 2012, consisting of 800 participants in nursing homes. Now, if I had to use the traditional, the most commonly used frailty phenotype in this population, it could have been impossible for me for different reasons. First of all, in nursing home, there is a so high prevalence of frailty, according to Fried, that might be quite useless to assess the status. I am not a sensible measure to changes to discriminate between the heterogeneity of the clinical profile. And then when we conducted this cohort study, we did not include in the data collection the 5 items described by Fried as necessary for calculating the frailty phenotype. It had different reasons, this cohort study. So we had the need of having an instrument that could have been implementable retrospectively on data collected for other reasons and whatever data was available. So these are the main areas that are investigated in INCUR. INCUR was a study that was funded by Pfizer to measure the prevalence of the incidence of pneumonia in nursing home. So there was just the idea of looking at how many persons in nursing home were developing this kind of condition. We get a geriatric, comprehensive geriatric assessment, multiple tests. These are the hypotheses of INCUR. Though it was not a study on frailty, but we wanted to work on this field in secondary analysis. The problem is that even if we had some measures, the SPPB, the gait speed, we were lacking of, for example, a physical activity questionnaire that is one of the criteria of Fried. So in order to have a measure sufficiently able to discriminate and measure the fragility, the vulnerability of the individual, we chose to use the Frailty Index. As I said, these are 800 participants aged 60 years and older, followed over 12 months of follow-up in 13 nursing homes in close to Toulouse. In this study, we have also had the opportunity to collaborate with the public health authority of the region in order to merge the clinical data collected during the study with the economic data, the costs of each patient sustained by the public health authority. So we have a clinical and economic database here. This is the Frailty Index that we have considered. as you can see, it's not a predefined checklist. I mean, we use the items that we had available in the court study and that were there for different purposes. There are diseases, there are symptoms, there are disabilities, there are signs. It's very, very heterogeneous, as it's supposed to be in the construction of this marker. This is the overall description of the population. It's a very old population, 86 years of age, predominantly women. And as you can see, there is a high prevalence of dementia, high prevalence of diabetes. The cognitive function is very low, and they are disabled. 2 ADLs and mainly no IADL are preserved in this population. So again, if I had to include here a measure of vulnerability of frailty, I might have a problem of floor effect here. I want to discriminate in a very frail population. And for this reason, we included the Frailty Index on the basis of the 30 items that I presented before. And as you can see, the Frailty Index here has a mean of 0.35. This means that it is a very frail population. Usually it is used a cut point of 0.25, 1/4 of the deficits considered as the cut point for defining frailty. So 0.35 is very consistent. It is interesting to see that in the Frailty Index, there is an assumption, I mean, that is quite usually reported in literature, for which 0.7 is the cut point beyond which it is pretty much impossible for a person to live. So the first study that we conducted was to look at the predictive value of this Frailty Index for mortality. And the Frailty Index is strongly associated with mortality. I mean, the number of deficits that the person has in this setting, even if it's a very homogeneous and very frail population, is strongly associated with mortality, even after adjustment for chronological age. We have also tested the Frailty Index versus a more clinical condition, the quality of life. Differently from the previous analysis, here we did not get a significant results. The Frailty Index was not associated with quality of life. So it is not true that everything that I test with the Frailty Index becomes positive. This is the evidence that, I mean, something negative can come out, probably because the quality of life of this population is difficult to assess, probably because there might be a floor effect and the profile is not sufficiently sensible, probably also because frailty, the deficit accumulation, is completely different from quality of life. We can just speculate on this cross-sectional analysis, but these are the results. And then there is another, the last paper that I wanted to just briefly sketch you is the use of the Frailty Index in the context of health economy. As I said, we have merged the clinical data with the economy data. And it's just an example of what we can do with this measure in geriatrics. What I did was to have the different nursing homes on the x-axis. And for each nursing home, we calculated the mean cost sustained by health authorities over the year on this axis, and the mean frailty index of the patient type in each nursing home. I mean, the frailty index of the nursing home. And as you can see, by crossing this data, we can find nursing homes that are very expensive with very low frailty index in their patients, and nursing homes that are very cheap, but with a frailty index that is very high. So this may just input a proposition for trying to merge this data, to use this kind of tools, also for allocating, for a better allocation of resources across settings, because I don't see that this is a definitive truth that one nursing home is working better than another, but at least we can check and see whether the use of money is consistent with the typology of the patients and take possible consequences. So In conclusion, what I wanted to show is that frailty is a condition that is important to be determined not only in the community, not only in prevention, but the vulnerability of the patients is always there because they are very, very heterogeneous. And even among the frailest and the more complex ones, we can always discriminate between different frailty profile, between persons who are exposed to a different severity of adverse events. Of course, the Frailty Index is one of the tools that we have available for measuring, but it's a tool as well as the others. So I think it's not important to stress whether at this point in the absence of gold standards to stress that one tool is better than another or to be two Talibans choosing one rather than the other. We should better think at these as instruments that serve for specific purposes, for our objectives, and we should be sufficiently flexible to move from one to another in order to collect information and data in populations like this that are not sufficiently studied. And these are all the persons that have been involved, and I would like to thank for their contribution in the INCUR study. Thank you.
Thank you very much.